Right, it's coming up 4 years ago that one of the GP surgeries in my consortium wanted to improve the care for patients, and the way that we felt that could be done was by all professionals involved working together. So myself, the practice nurse, and someone from district nursing. So as you can see, these were the people participating in the pilot. A very enthusiastic GP we had leading, myself and the district nurses. And I mustn't forget to say that also therapists did come as and when required to the meeting. So we did try to have as multidisciplinary as possible. We got our information from the district nursing and my caseloads, plus who the practice nurse knew. The surgery's vulnerable list, which those of you who work in GP practice are aware of, and also from the PAR tool, which identifies people who do attend hospital quite frequently. Our aim was the case management of frail elderly with comorbidities, providing integrated holistic care, improving the quality of the patient's life, which is very paramount, coordinating social care needs, to bring together all professionals, information about the individual patient. So we had a criteria, so it was patients with complex social needs, cognitively impaired, frequent exacerbations of long-term conditions, palliative care patients, chronic mental health patients, poorly controlled diabetics, high-risk fall patients, polypharmacy issues, and frequent A&E attenders. And those who were admitted to hospital were more than twice in 3 months, elderly patients with a greater than 2-week stay in hospital, and patients who were identified as high risk. Now, they may not have necessarily gone to hospital, but we identified them as high risk. How did it work communication-wise? We started with twice weekly meetings. Unfortunately, that was too much because we couldn't all get together. That's a lot of time out of your working week. We then went to weekly meetings, and they were 8:30 in the morning. But again, it was getting everybody together. So now we have monthly meetings, which are a more appropriate time of 1 p.m, and the surgery provides lunch, because that's where all the meetings are held, in the surgery. So that's a good incentive for people to come to a meeting. We have ad hoc conversations, face-to-face or a phone call to talk about patients. So you keep that momentum going, faxing information. And I use EMIS, which is what my GP surgeries use for records, and the practice nurse. And the district nurse, although they use a different system, Rio, which some of you may be familiar with, they were actually able to access EMIS as well. That was set up for them. The outcomes of the pilot were to prevent hospital admissions, facilitate early discharge, provide integrated care for patients, and improve the patient experience, which I hope we have. Problems. Turnover of district nursing. We've been through a spate where there's been a big turnover of district nursing staff, and have been occasions when we haven't had one at a meeting. The meetings and also the keeping of time go together. The meetings are supposed to be 1 hour long. Unfortunately, they have been sometimes as long as 3 hours. But when you've got a new nurse coming in who doesn't know anything, unfortunately you have to more or less start again and explain what's going on. And evaluation, well, the meetings are still ongoing. Although it's nearly 4 years since we decided to do this piece of work, it's still in progress. But it is going out to the other surgeries within my consortium on a monthly basis, thank goodness, so that makes it more easier. We still have a problem with the turnover of district nurses, unfortunately. There has been a lot of structural changes. We have improved communication. If anything, I think we're all talking to each other a lot better. Patient care has been, improved as well. I think because we are talking together, these meetings help. And we have prevented some patients from being sent unnecessarily into hospital as well.
So I'm going to talk to you about integration at a whole system integrated care level across the North West London patch. And I've been involved in many of the sorts of things that Marina's talked about over the years, and the thing that I always worry about, that concerns me about them, is when that really enthusiastic GP, that really committed community matron moves on, how's this work sustainable? How does it continue? How does the learning from it continue? So the purpose of this work is to provide a system that works with these enthusiasts, rather than what it feels like at the moment is currently we have a system that works against integration. So I'm going to talk to you about that. Across North West London has a local history around integrated care. Some of you might have heard of the integrated care pilot, which ran from 2011 to 2014. And certainly we've got a background of delivering around integrated care. So the integrated care pilot achieved a 7% reduction in people over 75 years being admitted to hospital as an emergency when compared to practices that weren't partaking in the integrated care pilot. And also we've got STARS, which essentially is a rapid response type service in Brenton Harrow, and the community integration service, which works across these three boroughs here. So lots of good practice and lots of enthusiasm to build on. Okay, so this is the patch. So the whole system's integrated care work goes back to the election really, and a new government, and a national driver to look for some pilot sites to build and demonstrate sustainable models for integrated care. So of course this is against a background of an increasing number of older people, an increasing number of older people with long-term conditions, and not just one long-term condition often, many long-term conditions. And a fixed budget, so no new money coming to the health service. So from a local perspective, and when I say local I mean this patch here, that's my local patch, it forced our hands to put our cards on the table and to talk and to commit to what could be achieved by when. And a whole systems integrated care application was submitted. Essentially the whole system's integrated care application focuses on the development of local organic processes, and each of the early adopters, which I'll come to in a minute, has decided to focus on exactly the same care group as Marina is focusing on. And I think that's because where the pressures in the system are. It's exactly that group of patients that end up being admitted inappropriately in and out of hospital, and nothing really changes in their care unless we're able to provide it differently and where they want it provided. So it's important to say that there's been some significant investment put into this programme of work. So since 2013 there's £10.2 million gone into this programme, and there's a further 11.2 committed for the future, and that's above and beyond any local CCG and provider commitments. I had a question in the previous group around the size of that investment, and I think the important thing to say is, given what we spend on this cohort across this patch, this is a drop in the ocean. I can't tell you whether it's 1% or 0.1% or 3%, but it really is a drop in the ocean. And the other thing to say is we all know there's no new money in the NHS or social care. In fact, social care has taken a much harder hit than the health service has. And so this isn't new investment, this is reinvestment. This is money being spent differently. So if we go on to the next slide, this one takes a while. I didn't do these slides, by the way, not part of my skill set. This one takes a while to come up, but there you are. It's a bit quicker this time than it was last time. It's 31 organisations involved in this piece of work, commissioners, providers and academic institutions. And I noticed there was a colleague here from the LAS. I imagine the LAS are involved in this too. I was just trying to see their logo there. I can't quite see it, but I know they're integral to the work. So let's move on. So once upon a time there was a vision for this work, and the vision was embedded in these key principles that care is provided around the individual in the same way that Marina's work is. It's provided in the most appropriate care setting, and I guess the difference between this piece of work is the scale of it. It's an enormous piece of work, but also it commits on focusing on the funding of care for this group of patients. So let's move on to the next slide. So down the side here, these ticked boxes are a set of principles that the whole systems integrated care pilot signed up to about what it wanted to change. And when I talked about the funding there, it talks about capitated budgets. We can talk about that a little bit more on the next slide. But there's a big piece of work going on at the moment that's above and beyond pooling budgets that people might be familiar with, that's actually hiving off the total spend for this patient group, including the primary care spend and the social care spend, and bringing it together as a capitated budget for this patient group. Where that capitated budget will land, I don't know, and some of that will be informed by the next election, I think, around which organisations hold them. But that's going to be, I think that's going to be fascinating to keep an eye on. Okay, so let's move on. There's 8 CCGs, and there's 8. There's an early adopter in each of the CCGs. They're all focused around older people with long-term conditions, with the exception of this one. Sorry, no, not with the exception of this one, with another one that's focused on mental health problems. And that's also, interestingly, about transition from acute to primary care. I'm talking to mainly nurses here, so I'm going to use this as a bit of a pitch, really. Engaging nurses in this work has been really difficult. Really difficult. Now, some of that's because of the commitments on our time, I think. But I think it's a real missed opportunity, because each and every one of these early adopters is looking at how we give care differently. And hence, what the caregiving role looks like. And I think it's really up to us as nurses to have a say in that and to think about what that should look like. So you may have heard the talk of care navigators, care coordinators. We talked about community matrons in the past, although they were essentially always nurses. And I think if we don't contribute to this discussion, we're at risk of throwing the baby out with the bathwater. I think we need to be clear about what we want nurses to do in this, and what the roles are we can supervise or relinquish to others. So if you get an opportunity to get involved, please do. Let's just move on. This next slide talks about one of the early adopters. So this is in central London, and basically it builds on the integrated care programme, which essentially focused on integrated planning of care. So this moves to not only the integrated planning of care, but the integrated providing of care. There are essentially across central London 3 hubs. They talk about 9 villages, and each of the villages has a multidisciplinary team. They risk stratify their patients, service users, in the same way that Marina talked about. Once risk stratified, those that are risk stratified have increased access to services. So home care visits, a rapid response service, reablement, there's clinics held in the hubs. And there's additional primary care funding going in too. That means home visits happen on a more frequent basis. And the GPs or primary care clinicians are included in the care planning. They're rostered for longer appointment times. So all their care needs can be met at those appointment times, rather than I've come to see you about my diabetes and I'll come back in 2 weeks' time to talk to you about my heart disease. And also primary care clinicians, including GPs, are being funded to take part in the MDTs and case conferences. Okay, let's move on to the next slide. Okay, so I wanted to talk to you a bit about the challenges. These are the 7 themes for the next phase of the work. But I wanted to focus particularly on the challenges, because I think it's always easy to get caught up into what's gone well. And I think if you spoke to anybody that was involved in this, they'd be able to articulate what's gone well, but they would also articulate what's been really tough. And some of them are some of the challenges that Marina talked about. So I can't remember if it was in this session or the last session, Marina, you talked fundamentally about how difficult it had been to work out how to share information. And that's been a key theme for this piece of work. And just not the sharing information, but the setting up of the governance to enable that sharing of the information. I cannot tell you how many information sharing agreements I've had to go through, how many committees to mean that people can share information. So that's been key and ongoing. And also, just to give you some idea of the scale, there's between 80,000 and 100,000 health and social care professionals that this work needs to touch. So it's a huge organisational development and system leadership and cultural change piece of work. And in that 80,000 to 100,000 professionals, there's significant change working in the capital at any one time. So it's not a once time only thing. You've got to keep redoing it and keep redoing it. I talked about the capitated budgets. Just a mention of further levers for change, primary care co-commissioning. So at the moment, CCGs have the responsibility for transforming primary care, and NHS England have the responsibility for contracting primary care. Primary care co-commissioning will bring those two things closer together again, which hopefully will help engagement. So the next slide just talks about where we are. As I said previously, I don't know if this is exactly today, but it's around about here, beginning to prepare for implementation. And then, the big scale up. And, this aspiration of whole systems integrated care being business as usual. Let's move on to the final two slides. In the last session, I had some handouts, but we had so many people, they've all gone. There was two things. When I was, as I said, this is very much part of what I do. It's not the only thing I do. And when I was thinking about what to talk to you about today, I thought, what are the two things that have really interested me about this piece of work? And so I just want to talk to you about them here and now, because I think there have been two things that are quite different. So we've categorically moved away from engagement and consultation with patients and users in this piece of work. In the conventional way that we did it before. So previously we would have said what we wanted to do, we would have invited some patients and users possibly to comment on what we wanted to do, and then we would have integrated their thoughts into that, possibly or possibly not, because we were too far down the path, and then we would have moved on to delivery. Patients and service users and staff, although not enough nurses as we'd like, as I said earlier, have categorically been involved in this right from the beginning, and the term being used is co-production. So they've helped co-produce the outputs of this piece of work, and I think that's been really interesting. It's been there's been quite a lot written about it in the journals about how it's delivering things differently, and the really important bit for me in that is that not only have we got to make a big cultural shift in professionals across the health and social care system, but we've got to make a big cultural shift in patients and users and how they use services. So, in a previous life, I spent 2 years setting up an integrated care service in terms of rapid response, and, it delivered really good things. But I can tell you, when push came to shove, patients still died 999 rather than ringing the integrated care service. And that was such a journey we had to take, particularly those who were suffering shortness of breath. And it was such a journey we had to take about changing their whole behaviour. And then this final slide, I think is an invaluable resource. So not only is all this being evaluated, because some of the 31 partners are academic institutions, but there's a website here that I'd really suggest you take down and you have a look at. The resources on this website are absolutely enormous in terms of integration. And it's not just our work, but it's the work from other places too. And if there's anything, if you're thinking about doing anything locally and you're thinking about, I wonder where else have done that, and I wonder how they would do it differently now, then this is exactly the place you need to be looking. because if you talk to them about how they do it differently now, they may start in a different place. So I'd really, as I say, I had them printed out for the previous group. I'd really commend people just to spend, make yourself a cup of tea, cup of coffee, give yourself 20 minutes and just have a flick around and find that useful.